Good afternoon, everybody. So today afternoon, from the Department of Medical Oncology and our allied departments from Pathology, Pulmonary Medicine, and other contributors from Radiology and Nuclear Medicine, uh, our team is going to present on a very interesting topic. We keep talking about targeted therapy, liquid biopsies, and lung cancer is the prototype for these two terms. And in the next 55 minutes, we will have our team with the allied departments presenting on this topic. And we hope that we all learn from this entity. Over to Prabhat, who has been leading the lung cancer program from our department.
Thank you, sir. So, many of you who have seen patients with lung cancer, maybe 10 years or 15 years ago, you would agree with me that at least in this disease, we have moved from an era of therapeutic nihilism some 10 to 20 years back to an era where we have a cafeteria choice of treatment to the extent that we are literally spoiled for choices for one individual patient. I mean, this is where we started. This is a New England Journal of Medicine paper in 2002, which showed that whichever chemotherapy backbone you use in this disease in advanced stage, the outcomes are equally bad. And these were considered new generation chemotherapy agents at that point of time. And 20 years later, and again in the same New England Journal of Medicine, you have a subgroup of lung cancer patients who are in that to an advanced stage disease with these novel molecules. You are getting a progression-free survival beyond 5 years. In this paper, the median has not reached in the new molecule group. And now we have 5-year update of this trial. We showed that almost 63% patients in advanced disease, they were progression-free at 5 years. So this is a kind of remarkable journey which we have seen in this deadly disease. And this has been possible because of better understanding of disease biology. We have moved from the era where we used to treat all lung cancer patients alike, and from the histological subtyping, adenocarcinoma, squamous cell, small cell, non-small cell, we have understood it at a genomic level that there are various subtypes of even one particular histological category, and more recently to the transcriptomic subtype, which tells us about the disease biology in a better way. And what are the basic clinical implications? We understand the specific genomic pathways which are activated in these subgroups and how to target that. We understand even the cell of origin for a specific type of lung cancer. If we look at the molecular subtyping, in today's time, we can actually classify the non-small cell lung cancer. More than 2/3 of the cases can be classified in a specific molecular subtype. And there are ethnic variations. If you see the Western profile, which would be different in terms of mutation frequency, and the Indian patients would be different. Particularly EGFR mutations, which are less common in Western populations, which are quite high. Almost one-third of a patient have EGFR mutation, and KRAS is less common in this part of the world. And that further highlight the importance of the regional data and the regional study for molecular subtyping. And it's not only that you identify the mutation type, it's important that you identify the right patient and treat them with the right drug. These survival curves tells you that if you have a patient with a particular mutation type and you treat them appropriately with a targeted agent, they have a significantly better survival as compared to patients who do not have a mutation, or who have a mutation but you don't treat them appropriately. And I mean, this is the plethora. You know that more than 2/3 can be classified into a specific molecular subtype. And for these molecular subtype, more than 50% of patients have either an FDA-approved treatment or a treatment which is available in the form of a clinical trial. And not only one type of treatment, you have multiple options for individual subtypes. So that's these are the different molecules which are approved for treating a specific genomic subtype in lung cancer. But for identifying a specific mutation, you need a tissue. And in lung cancer management, tissue is always a big issue because the biopsies are critical. You get a very small tissue. So what are the ways to obtain an appropriate tissue and how to handle this? Our colleagues from Department of Pulmonary Medicine, Professor Anand Mohan, would tell us about the techniques.
So, thank you, Dr. Prabhat. And as mentioned, when it comes to molecular testing and appropriate therapy, it is always we need adequate tissue sample adequacy to be able to delineate not just the morphology. Earlier, it used to be just to tell whether it's a small cell or a non-small cell. Then the pathologist started doing immunohistochemistry, other markers to further subclassify squamous, adeno, and all other variants. Then now one needs to do molecular testing. One needs more tissue, more cells to be extracted. So always it is the amount of sample adequacy, and for that now all our kind of efforts are towards that direction. So what is the role of the respiratory physician for adequate tissue sampling when it comes to lung cancer? There are two things that we have to do. Basically, one, we have to decide on the site from which we have to sample. There may be multiple sites in the body. We have to select the most suitable site, and that is decided by a team MDT comprising of all the relevant doctors, including the radiologists. So whichever is the easiest and most likely to give us the diagnosis and adequate, that we do. And then decision on the mode of sampling, again to collect the greatest quality and the quantity. Both are important with the least risk to the patient. So these are the two main decisions that we have to take. Obviously, they are guided by the clinical condition, the disease stage, the site, and also what equipment we have with us. Now, if we come to the the type of modality, the diagnostic modality that we choose, depending upon the location, whether it's a central or endobronchial or it's a peripheral. So in this situation, obviously, it is the various bronchoscopic techniques that I'll be talking about very briefly, where we can do the biopsies. For bigger tissue, we can now do the cryobiopsies, the brushings, washings, and the lavages. They have all been there for a long time. When it is a peripheral tissue, so I am not talking about a transthoracic route right now, that obviously is there. I am limiting myself mostly to the bronchoscopic modalities that we have. We have the ultra-thin bronchoscope and the radial EBUS, through which we can take PBLBs, we can take transbronchial cryobiopsies for bigger tissue, needle aspirate washings and brushings. And of course, we have the linear endobronchial ultrasound for central tumors that all of you must be knowing, the central lesions, mediastinal nodes. They all can be accessed very nicely by the linear EBUS. And now new are the various other methods now coming. So to increase the sample size, we use nodal forceps biopsy or a nodal cryobiopsy through the EBUS scope, and I'll talk about that in also a little bit brief in some time. So these are the sampling modalities. This is our radial, this is our linear probe EBUS, and this is how it looks like. So if we put it in the trachea or the tracheobronchial tree, this is a node, and this is how the needle comes out. You can see the corresponding image here, needle and the lesion, whatever is that. And this is under direct vision. This is the radial probe EBUS, which has a probe here, and it kind of gives a 360-degree angle when it is switched on. So if we put it inside the trachea or the bronchus, this is a lesion around it. This is the kind of image that we get. So this is an abnormal lesion. And we know that, okay, we have to put the forceps here, and here we take a bite, and that is how we access. And this is just a depiction of a virtual bronchoscopic navigation. It is there which gives us a guide map. So it guides us into the bronchus as deep down as possible, directly to the lesion wherever it can be. So it's a kind of a GPS system that we have in automobiles. So the challenges that we have, of course, as we said, adequacy for diagnosis and adequacy for molecular analysis. These are the two main things that we have to look at. And what is the yield of all the techniques I've talked about? Again, see, for diagnostic yield, this is the yield for various techniques for diagnostic yield, and this is the adequacy for biomarker. Both the things are important. For diagnostic yield, bronchoscopic methods are anywhere between 70 to 90%. When they are combined, the yield is definitely much better. For radial EBUS, it is around 60 to 70% when they are all combined. For EBUS TBNA, if done properly and along with the clot core, it may go up to beyond 90% also. Even for adequacy for biomarker testing, as you can see, they are pretty good. In washings, they are not too good, but in biopsy, if taken adequate pieces and adequate size, they are very, very well equipped to give us biomarker testing yield, 70% for radial, and again 70 to 95% by the linear probe EBUS. So just means to say that we can use this for biomarker molecular testing as well. And this was just to show the yield of diagnostic procedures bronchoscopically. This is from our own department. This is what we did as part of one dissertation out of around 500 procedures. You look at this part only. When we combine modalities, then our yield definitely is much better as compared to solo modalities, somewhere around 80 to 83%. In EBUS TBNA at that point of time, it was just around 66%. But again, when we combined with the clot core, 77 to 78%. So yield increases by combining techniques. So that is one method. Now, the next part is for how good are these sampling methods for the NGS. Now, you know that molecular methods either by PCR or by NGS. They are the two main things. In this study, a very recent study actually around, I think, 2022. So this just focus on the extraction of DNA and RNA from the samples. If you see from the total all samples, almost 85% were successful for the NGS, DNA more than 94%, RNA also in a pretty good proportion. And if you see the breakup, this is a transbronchial biopsies. Again, you look over here, DNA, RNA extraction was possible in a good majority of the patients. Even in EBUS, almost 100% DNA and good amount in RNA. Surgical biopsy, of course, did very well. And even in fluids, although very less number of samples, but they also did very well when it comes to molecular testing. Most of this was pleural fluid and CT guided biopsy also. So this just shows that various modalities are pretty good when it comes to extraction of DNA and RNA, which is the cornerstone for molecular testing. Now, size, of course, is an important issue as far as this molecular markers are concerned. So in order to increase the size of the tissue, what do we have? We have the cryobiopsy, in which we freeze the probe. So this is a cryo probe. Over here, when we switch it on, it freezes like a ball of ice. And this comes in contact with the tissue, and then we pull it out, and the whole tissue comes out. And you can see this is almost 4 to 5 times the size of a simple forceps biopsy that we get by a bronchoscope. And over here, you can see not just for diagnosis, but even for extraction of DNA and RNA, almost 3 to 4 times greater amount was taken out using the cryo probe as compared to the simple bronchoscopy biopsy. So, and even for PD-L1 expression, it was better. Cryo biopsy was better than the conventional 51%, 42% for PD-1 expression as well. So by this, if you do this, then we are able to get better amount of tissue for molecular testing. Again, in the same way, in a very, very recent paper, again, a retrospective one, small one, but important nonetheless, because a new technique was compared, EBUS cryobiopsy. Here, instead of the simple EBUS needle, we put a probe, that cryo probe, which I just showed you, we put in through the bronchus into the node, freeze it, and pull it out. So again, it gives a better piece, a bigger piece of the mediastinal tissue. The overall yield was much better, as you can see, 96% versus 54%. And all of the samples which came out from the EBUS cryo facilitated the acquisition of NGS and immunohistochemistry analysis more readily. Again, by doing this, one is able to perform molecular testing to a reasonably good certainty. And this is how it is done. So this is a cryonodal biopsy. This is the probe which you can see. This is the tip of the probe, which is frozen. This frozen part cannot be seen, but here you can see this is how we are putting this through the tracheal wall like this. And this is the tissue we get when we pull the whole thing out. It is much bigger than what we get routinely through a needle. Needle only gives aspirates. This gives a tissue piece. And also the same thing has been done using a forceps, a small thin forceps, and all of them give yield in excess of 90%. And the diagnostic yield is also, almost somewhere 70 to 80%. And this was actually a paper from across the road from Safdarjung, in which they compared all the 3 diagnostic modalities. Quickly, other methods to increase the tissue size and the yield, use a thicker needle. So 19 gauge is thicker. Obviously, it will give us better core of tissue. There are many innovative needles coming up with a cutting edge, Franson's needle. So they all have, multi-pronged cutting edges, which grasp better, which pluck out the tissue better. They are not yet so freely available, but I think in the next couple of years, they'll be there. The role of suction, not very sure, but number of specimens for us is important. So at least 4 to 5 biopsy samples for the primary diagnosis, and more if we need to do molecular testing has to be done. If we are doing EBUS, at least 3 to 5 specimens must be done, if not more. Also put in some samples in the clot core, so in formalin, that also helps in histopathology. If there is a metastatic site, definitely we prefer that, because we can get a diagnosis and staging both in the same go. So in that way, I think it really helps. Lastly, we are always looking for more and more non-invasive techniques, because all the methods I described, they are all invasive techniques. Suppose we can't do that. Suppose we want to do something non-invasive and more easily collectible. Many times patients are too sick. They are not able to undergo biopsy, bronchoscopy and everything. So there are some newer things that we are testing out, and this is one which is analysis of the exhaled breath condensate for diagnosis of lung cancer. And this is just a couple of one of our patients who's trying to collect the exhaled breath over here using an e-nose and all. We are trying to look at volatile organic compounds. We are trying to look at microRNAs, and initial results have been encouraging with almost a ROC of 76.76. We have been able to discriminate controls versus lung cancer. MicroRNAs are doing much better, and we have been able to find a panel of 3 to 4 microRNAs which are very specific for lung cancer with an AUC of almost 95%. So these are preliminary data, and we are also testing this now for mutation, because that is the topic for today. So we are testing exhaled breath for mutation testing also. Can we use it for mutation testing? So that, if yes, we'll see in a couple of years. If we get something, we'll come back to you on that. So I think that was from my side, and for further on molecular testing, I'll invite Dr. Deepali from pathology to carry.
Thank you, sir. Good evening, everyone. I'll start with this slide, which already has been briefed by Dr. Prabhat, that our understanding from the pathology perspective has advanced significantly during the past 2 decades or so. So from simply classifying lung cancer into small cell versus non-small cell, now we have moved to specifically histotype them into squamous and non-squamous morphology for targeted therapy. And now the focus has also shifted towards examining oncogene addiction and role of immune mechanisms, whether a tumor is particularly immune driven or they are immune cold tumors, for deciding about immunotherapy purposes. So things to keep in mind is that the most diagnostic samples which we receive in the department are small biopsies and cytology specimens, where we not only have to histologically accurately subtype them, but also we need to triage the material for molecular testing at baseline as well as during treatment monitoring. So in a single patient, if we combine all cytology and histology specimens at one time, we will have maximum this much amount of material, and we need to perform all molecular testing and diagnostic testing on these specimens. So we had to manage quite judiciously. So we do not waste tissue when the lineage commitment is quite clear-cut in terms of squamous and adenomorphology. We do not do any testing, and we save tissue for molecular. But in a poorly differentiated cancer, we apply immunohistochemistry on histology and cytology specimens alike, because cytology specimens are also equally good for performing ancillary testing. So after diagnosing non-small cell lung cancer, non-squamous phenotype, the next important step is to conduct predictive biomarker testing. And as per all recent guidelines, they recommend doing 5 mutations, 4 fusions at least, and PD-L1 IHC. So in total, 10 or 11 biomarkers for lung cancer. Of course, by multiplex testing, because it makes sense. Single gene testing is not going to work for all these biomarkers. And they say that wherever resources are available and wherever targeted drugs are available for all these biomarkers. But having said that, in Asia, EGFR mutation frequency is higher. And Asian guidelines still recommend doing single gene testing for EGFR, ALK, and ROS1. And that is what we do here at AIIMS. So for that, we need to plan our specimens in such a way that we will be able to do all these biomarkers in one specimen. So we make multiple blocks separately for IHC and FISH, and a separate block for molecular testing for extracting out nucleic acids. Cytology specimens, as I said, they are collected in non-formalin-based fixatives. So they offer the possibility of even higher quality nucleic acids in comparison to histology specimens. So wherever need arises, we try to do mutation testing on cytology specimens also. And tumor enrichment is key to success in cases where tumor fraction or tumor content is less. To avoid false negative mutation testing results, we perform it by manual methods, but there are more sophisticated techniques are available in market. So this is here is the data from the past 3.5 years, in which we nearly tested 2,000 lung cancer patients, non-small cell lung cancer patients, where we tested EGFR mutations by qPCR method, ALK and ROS1 gene rearrangements by IHC testing and FISH analysis. Prior to 2021, we published our data on spectrum of EGFR mutations in lung cancer patients in Lung Cancer 2020. So if you see this chart, we can see that the frequency of EGFR mutation over all these years has consistently hovered around 30% or so. So a third of patients have EGFR mutations, and as expected, DEL19 and L858R mutations account for approximately 80% of EGFR mutations. And typically, well-differentiated and TTF1 positive tumors are more likely to show EGFR mutation, but that is not always the case. ALK testing, we do it by a companion diagnostic IHC assay, and wherever IHC is equivocal or doubtful, these cases are subjected for FISH testing for confirmation of ALK rearrangement. And usually solid mucinous and signet ring cell morphology is predictor of ALK rearrangement, but converse is not true. And as I said, we use cytology smears for FISH analysis, wherever we don't have tissue available. ROS1 IHC testing, unlike ALK, where we subject equivocal cases for FISH testing, in ROS1, all ROS1 IHC positive cases are subjected for FISH because ROS1 IHC is non-specific. So diffuse and strong intensity IHC is confirmed to be ROS1 rearranged when on FISH, ROS1 gene shows break apart of these signals. So in more than 15% of cancer cells, then it becomes ROS1 rearranged lung cancer. Otherwise, in 10 to 30% of the cases, because this IHC is non-specific, ROS1 is also intact. So for confirmation of ROS1 rearrangement, we need to do FISH testing or other orthogonal method for confirmation. So this is the data we have published on concordance of IHC and FISH in ALK and ROS1 testing in 1800 plus patients last year in this journal. So this pie chart illustrates frequency of EGFR, ALK and ROS1 positivity over the past 3.5 years. Still, you can see that a significant portion of lung cancer patients are triple negative. So to address that triple negative cancers, we have developed and validated custom gene panels, NGS panels for DNA mutation and RNA fusion. So this encompasses all recommended biomarkers, and soon we are planning to use these panels in patient care. Moving on to liquid biopsy segment, where recent consensus is that plasma first approach can be made in patients where tissue is not available, or we can just test by plasma first approach, where plasma first approach shows positivity for tissue tumor genotyping, then patient can be started on targeted therapy. So not only in TKI resistant settings, but also at baseline. So we applied this plasma first approach for EGFR mutation testing because we have more EGFR by qPCR and ddPCR method in 500 plus patients. And an additional 130 patients were tested via liquid biopsy in TKI resistant setting for EGFR T790M mutation detection. So this is the year-wise distribution of frequency of EGFR mutation, which is more or less similar to tissue. And again, L858R and exon 19 deletions are predominating here as well. So when we compare the turnaround time in revelation of EGFR status for starting TKI, the turnaround time was significantly shorter when we tested EGFR mutation via liquid biopsy in comparison to tissue biopsy, where the turnaround time was high. We also used other cytology specimens for extracting out cell-free DNA and then doing molecular methods. For example, pleural effusion supernatant, which we usually discard, but these are also rich sources of cell-free tumor DNA, and we subjected them for NGS, and it works well. Similarly, urine was also used as a pilot project for extracting out cell-free DNA and detection of EGFR T790M in EGFR TKI resistant setting, and ddPCR was applied on them. So these all are good resources for doing mutation testing. PDL1 we do as on request, we do not do as a reflex testing in squamous as well as non-squamous cell carcinomas. And we have validated this IHC. This is quite fragile, I would say, IHC. So it has a lot of challenges. So we have validated it on cytology cell blocks. We do not do it on smears of cytology and cytospins because it has its inherent challenges and limitations. So in nutshell, as you can see here, the Department of Pathology actually plays a crucial role in management of lung cancer patients, beginning from the diagnosis to predictive biomarker testing and treatment monitoring of these patients. So my sincere acknowledgement to my lab staff and my colleague, Dr. Aruna, she's here, without whom this work would have not been possible. Thank you.
Thank you, ma'am. So at this juncture, our pulmonary medicine team, they have given the tissue, and our pathology team, they have given us all the molecular information. So as medical oncologists, our task is to translate this molecular information in patient care. So this is the paradigm for molecular biomarker positive advanced non-small cell lung cancer management as of today. You can see that this is a humongous information which bombards us incessantly in our day-to-day practice. So the management of advanced lung cancer, apart from biomarker, also depends on the age, performance status, comorbidity, and of course the availability and affordability of the drugs. In today's era, we have a plethora of choice in the first line treatment. As we can see above the vertical dotted lines, we also have lot of choices in second line as well, the drugs that are in the below the dotted lines. So I will share our RCH clinical experience from 2021 to 2023. 2,400 patients were registered in lung cancer clinic at this time. So we excluded other diagnoses apart from lung cancer. We also excluded small cell lung cancer, and where data was not available, we also searched pathology database and removed the duplicates. So finally, we arrived at 663 cases with at least one molecular test and complete workup. So coming to the baseline characteristics of the whole cohort, it is pertinent to note that the baseline characteristic of this cohort may not be the same as of the classical textbook description of the lung cancer cohort. Since this patient consists predominantly of adenocarcinoma, and some patients are of squamous cell carcinoma who were non-smokers. So the median age of this cohort is 56 years with predominantly male patients, non-smoker. Approximately 44% of patients had a good performance status of 0 to 1. Approximately 8% of patients had family history of any cancer positive. The diagnosis was predominantly made by biopsy in 94% of patients, followed by fluid cytology and fine needle aspiration cytology. As said earlier, the predominant histology is adenocarcinoma in 88% of patients, and almost 90% of patients were stage 4 cancer. 367 patients had undergone liquid biopsy for EGFR alteration, out of which 35.4% were positive. The predominant mutations were EGFR deletion 19 followed by L858R. 569 tissue were processed for EGFR mutation, out of which 42% were positive for the same. ALK rearrangements were seen in 12% of patients, whereas ROS1 rearrangements were seen in 3.5% of the patients. Coming to the mutation profile of this cohort, almost 42% of patients, no mutation was detected, and approximately 40% of patients had EGFR mutation, followed by ALK rearrangements and ROS rearrangements and KRAS. It should be noted that these rare mutations, they are underrepresented, as comprehensive genomic profiling was done only in 53 cases. So comparing between mutation positive and mutation negative patients, mutation positive patients, they tend to be younger with proportionately more female patients, non-smoker, adenocarcinoma histology. They present more in advanced stage along with brain metastasis. Now I request Dr. Aparna to share the treatment details of this group.
Good evening, everybody. So after a brief summary of our patient characteristics, now some real world data of how we treated our patients. So let us start. So around we had 521 patients at IRCH and NCI, that is roughly 79% patients who were able to receive treatment in first line. And since Dr. Deepam highlighted that 89% of these driver mutation positive patients were metastatic, so around 4.2% of these patients had underwent surgery. And curative definitive chemoradiation, a small chunk, that is around 2.8%. However, a large proportion of patients underwent palliative radiation to the painful metastatic sites. Now, how did we treat these patients systemically? So around 492 patients received treatment in first line, and out of them 50% of our patients received chemotherapy as a first line therapy, 34% TKI alone, and the recent evolving data of combination therapy. So around 14% of our patients received TKI as well as a combination of chemotherapy. And of course, there were only 2% of them could receive immunotherapy as well as chemotherapy. There were some cost constraints obviously involved and accessibility issues with our patients. So after receiving the treatment, what were our outcomes? So this is the progression-free survival of the combined cohort of our driver mutation positive patient with a median progression-free survival, which means from the point of starting of the treatment to either progression or death, a median PFS of around 1 year. Again, if we classify them between driver mutation positive and negative patients, we see the driver mutation positive patients doing slightly better. However, the most important slide out of the outcome analysis is, as highlighted by Dr. Prabhat, further reiterating the fact that a mere possession or identification of a driver mutation positivity is not the thing that predicts the excellent survival that we are getting in today's era. It is about exposing them or addressing them with a driver mutation therapy, a TKI. So here we see that those patients who were given a TKI or a targeted therapy did, so we can see the red graph highlights those patients who were exposed to a targeted therapy, and whereas those patients, the green and blue lines, show those patients who are driver mutation negative or those patients who are driver mutation positive, however, did not receive a targeted therapy. Again, after first line, there are many patients who received TKI as subsequent lines or second line, and even them, the median PFS or the survival were around 14 months. So further delving deeper into the different type of mutations that we have in our patients, as Dr. Dipali ma'am highlighted, EGFR being the commonest. However, although these numbers are small, we see the ALK positive patients doing slightly better than the other driver mutation positive patients. Again, progression-free survival, we come to the overall survival, and we see our patients, those who are driver mutation positive, doing well. And again, mirroring the same results that we saw in the introduction, the different evidence from all around the world, the progression-free survival, again, re-emphasizing that on the overall survival curves too, that those patients who received targeted therapy did better than those who are, even though are driver mutation positive, however, did not receive targeted therapy. Since EGFR is the commonest mutation in our population, a little bit about our EGFR mutated patients. So around 212 patients out of 263 received therapy, and out of them again 130 patients receiving it as monotherapy. And as the maximum existing evidence about combination therapy is in the EGFR positive subgroup, we had around 61 patients who received a combination therapy of TKI as well as chemotherapy. Again, in the EGFR positive patient, we see that the combination therapy, the patients who were exposed to combination therapy versus TKI alone did slightly better. Now, the whole paradigm shift of chemo progressing, then going over to TKI, that is target mutation, and the recent evolving evidence of combination therapy, TKI plus chemotherapy. We are now coming into era of precision medicine. Can we further stratify or intensify our treatment on the basis of a liquid biopsy or molecular test? Seems so. So this is a study conducted at our center, a dissertation by Dr. Hemavati, our DM resident, under the mentorship of Dr. Prabhat. And this study tried to see if we can integrate liquid biopsy in the treatment decision making of driver mutation positive patients. So just an overview of the study design. So the patients initially, so this was in the EGFR mutation positive advanced NSCLC, that was the inclusion. They were initially exposed to TKI, Geftinib, which is our first line TKI, and after 9 to 12 weeks, there was a reassessment of a radiological assessment as well as the plasma ctDNA by liquid biopsy. So now stratification into two arms. Those patients who had clearance of ctDNA continued on the TKI alone arm, and those patients who had residual ctDNA and radiological response, they were augmented to addition of a combination therapy of 4 cycles of chemo along with TKI. And a progression-free survival was assessed at 6 months. A brief overview of the results, a brief snapshot. So we could enroll around 69 patients, and out of them we could assess around 62 patients. So like we see, the ctDNA positive patients, the patient who did not clear their ctDNA, around 31 patients, and 4 cycles of chemo was added, and out of them around 25 completed their intended cycles of chemotherapy along with TKI. 26 patients had clearing of their ctDNA and they are still on TKI. Out of these patients, 5 patients actually progressed while on therapy and 3 succumbed before analysis, probably indicating the aggressive biology of the disease in these patients. So again, we see in this precision medicine approach, we see that a combination therapy in those who had, which was driven by the liquid biopsy or the molecular test, had a better, slightly better survival than those who had given TKI. So this study formed the basis of a phase 3 study that we have planned. We have recently received ICMR funding for this project. And this is a phase 3 study where we will be assessing liquid biopsy guided addition of chemotherapy with TKI in all the advanced EGFR mutated non-small cell carcinomas. It is a phase 3 study. Just a brief methodology. It's a randomized control trial where this is the standard of care. The TKI physician of choice along with chemotherapy will be assessed with a stratified approach where initially a TKI alone will be started and a ctDNA positivity, and then we will see the liquid biopsy and the ctDNA positivity. And again, as we did it on a previous study, those who did not clear or had liquid biopsy or ctDNA positivity will be augmented with 4 cycles of chemotherapy along with TKI versus TKI alone. So with this, a lot of data, a lot of figures. So to make sense of all this data and to conclude and summarize this whole presentation, I would like to call upon Dr. Sachin Khurana.
Thank you, Aparna. So we have seen diagnosis, we have seen how to extract tissue, how to diagnose it, and then our own data. If you remember, we started from this curve, and Aparna also highlighted that in our patients, those who were some mutation positive and were given some targeted therapy, their outcome was better than those who didn't have any mutation or who were not able to receive any targeted therapy. So this is the same graph. I would just like to re-emphasize, find out a mutation and try to give some targeted therapy. The outcome will be much better as compared to other patients. And what drugs are all available with us? This is the whole, I can say, the armamentarium of our drugs in targeted therapy in lung cancer. The red ones highlighted here are not available in India, and all others are available in India. And but it's easier said than done because the drugs are available, but in spite of that, our patients are not able to receive the best therapy. The reason is affordability, And this is one of the papers which has highlighted how to address this issue. What they say briefly is identify and acknowledge the problem, engage the stakeholders, and try to find some workable solutions. I think that has to be done at the policy level, and it should be addressed. Otherwise, we can always talk about drugs, but patient receiving them is just another thing. So, what are the takeaways? If you say what we have tried to convey today, need for adequate sample for biomarker testing. This is very important. Prioritize sample, use it judiciously, complete the molecular testing, preferably in future we will be doing NGS only, and then select a proper targeted treatment. This is some of our own data which we have collaborated with other investigators about EGFR and ALK rearranged patients and how they have behaved after we have given them targeted therapy. So, and another for this is for students. This is something which gives a comprehensive view of genomics and application through targeted therapy in lung cancer. This chapter has been written by Dr. Prabhat, and it is a must read, I would say. So yes, the future is bright, but it will be definitely very complex for us. So newer and newer data is coming up, and I think the precision oncology will take its turn, and it is going to be extra precision oncology in future, but of course very complex. So here I would end and would invite Dr. Prabhat for the concluding remarks.
So thank you, everyone. And as you can see in this figure, probably that's the future. That's what we expect in some time, that we will just have all the information about the patient in form of a chip or a scanner. You just scan and decide on your treatment decision for individual patient and individualized treatment for every patient. That's going to be different. But I would agree that in this era where we are getting a lot of information, even for a clinician, you get an enormous amount of molecular information, and it's becoming more and more difficult these days to remember all these alterations, its biological significance, and selecting the right drug and the right treatment, managing their toxicity. So it is becoming more and more complex for medical oncologists these days. And it's not, this entire work is not a one man or a one department show, it's entirely a teamwork. And that's how the treatment decisions are taken in our clinics in day-to-day practice. We get the good sample from pulmonology department and intervention radiology. They are the key people to actually make this all possible. Then we need a good pathology, molecular pathology backup, which gives us all this information. People from basic sciences, bioinformatics, nuclear medicine for doing functional imaging and doing response evaluation, surgical colleagues, radiation colleagues for individualizing treatment. It's not that all metastatic diseases are same. In fact, in many of these metastatic cases who have wonderful responses with targeted agents, some of these patients undergo surgery and sometimes curative intent radiation. So these are case-to-case basis decisions we take in our day-to-day clinical practice. And last but not the least, the palliative care, because majority of these patients are advanced disease. Whatever we do in the beginning, but at the end of the day, they progress and they end up. So you need people to, counsel and hold and provide them a good supportive care. So with this, I would acknowledge the funding. Many of these work, which when we started was done based on some research project, and later on we took it to the clinic. Many of these treatments have been provided as a part of pharma-sponsored clinical trial or academic clinical trials. There are, this is not just one department or one team, it's many people's contribution, either directly or indirectly. I would like to acknowledge them, our research staff, which have helped us to put all these data together so that we can make some sense out of it. A funding agency, patients and family member, and our alma mater, AIIMS, which has actually given us this platform. Thank you very much. We'll be happy to take any questions.
Can I have questions from?
Any comments or feedback? Yes, sir.
not have it. But what was non-smokers,
So basically, I mean, the cohort which we are talking about today, I mean, these driver mutation positive, they are predominantly non-smokers. So this is a disease of never smokers if we talk about EGFR and ALK and ROS1. So these are a very classical never smoking signature. Why they are getting it? This is, I mean, and in fact, these are younger patients, relatively younger patients, more female patients. So, I mean, in fact, that's what drive us in the clinic, that if you find a patient, that's a classical teaching in oncology, if you find a never smoker female, that too, or a young patient, never forget to do a driver mutation, because the probability of finding a targetable alteration in this specific subcohort may reach up to 60 to 80% if you do a comprehensive profiling. I mean, you may find a drug for them. So in terms of frequency of smoking, I mean, if we go, like if we just look at the pan-India data for lung cancer epidemiology, so smoking is relatively more prevalent in the northern regions. And if we go down south, I mean, whatever data we get from the institutions in southern part of the country, the frequency of never smoking lung cancer is relatively higher.
so in the northeast and in the hilly area of Uttarakhand and all, the prevalence of smoking is, I think, probably the maximum.
Yes.
That is one thing. About the non-smoking part, in females, obviously they are young, but one thing which we do not take into account is the biomass exposure, which is not counted as smoking per se, but it is an important cause of respiratory disease nonetheless, including cancer to some extent. We don't know how much it will cause, but it contributes at least to COPDs and all those things, maybe to lung cancer also.
No, that has been considered traditionally as one of the important risk factors for lung cancer causation. But as the urbanization is increasing, I mean, access to clean fuel and access to LPG and all is increasing in our country. Probably over a period of time, that factor would reduce. But the way the air pollution is increasing, I mean, that's being considered one of the important risk factors for lung cancer.
And so lung cancer, females is actually on the rise.
Yes. If you look at the registry data, if you look at the last 20-year patterns, so lung cancer is reducing in males and in females is increasing. Yeah, please.
For few months, I think, in physiology. We are very proud that AIIMS and globally. We are very happy.
Yeah, thank you.
Like you said, all this is really good. Spirit of AIIMS. Best.
Thank you, Dr. Samir, for the last word.
Great. We all learned inputs from everybody for the allied departments. Thank you all. Any other comments from anybody?
Interpretation that the social demographics and maybe the stress component and so palliative care would work. Let's say some reference or cross reference some consultation wise or something.
Right.
Lifestyle. Something else, driving cars. Some things may come up.
I mean, completely agree, ma'am. I mean, saying that you have this wonderful armamentarium of treatment, but at the end of the day, you need people to really talk to them and a good support group. I mean, in fact, like when we see patients diagnosed in their early days, maybe 30s or 40 years of age, and the kind of psychological trauma they have, and that the entire family undergoes. So that's important. I mean, it's as a forgotten area when we sit in the clinic or in a busy clinic, but that is something really very important and should be.
caregiver's experience.
Absolutely.
Can you give us a virtual history and then we will elaborate what would be the contributing factor?
Certainly. Quite. Thank you. Yeah. Yeah, so liquid biopsy as such, if you look at the specificity, it is reasonably high. The sensitivity is relatively low. And although we are using RT-PCR and ddPCR, which is, I would say, a sensitivity of around 60 to 70%. If you do use NGS-based method, it may improve further by another 5 or 10%. The best case scenario, it remains up to 80%. If you by only liquid biopsy, you would lose 20% of odd patients. But if you combine these two approaches, because many a time you don't have enough tissue for testing, if you combine these two approaches, your yield would be the maximum. Thank you.